All right, so without further ado, from Fran DPT program, Phil Page, I will turn it over to you. I will shut my mouth and mute my mic and let you take it away.
Thanks, Nashville, Ashley. I am in Baton Rouge, Louisiana. I am the Associate Professor and Director of Research at Pvalue, and also an editor of the journal. In full disclosure, I do not have any other, I don't know how anyone could have a disclosure related to statistics, but we're going to get started with that. So my first disclaimer is I am not a statistician. If you are the one person that said you're an expert in stats, I'm really sorry. Don't take any offense to this. I am not a statistician, but what I've learned over the years is that you don't have to be a statistician to understand statistics when it comes to rehab. And we'll talk about what that means. So just to let you know, I am not a statistician, but I did sleep at a holiday. No, that's a different joke. Anyway, when I talk about statistics and I throw this word out, how many of you out there have these reactions, right? There's nobody that gets giddy about stats except for that one person who said they had an excellent response to stats, or, you know, someone like me who just nerds out, or my friend Omar Ross, who's probably listening and had this same kind of attestment that nerds like stats. Well, that's not always true. What stats are about is really about how do I apply this to my patients. And I was, you know, upfront and honest, I was not a big fan of stats when I did my PhD. I did whatever I could to avoid having to take them, but it intrigued me in how people were using stats in making conclusions and therefore decisions about research in the clinical setting. So I kind of took it upon myself to do a little bit more in-depth review of how we can use statistics to our advantage rather than having all these reactions of, oh my gosh, I can't stand these things. This just blows my mind. My goal tonight is really about, you know, getting you past that feeling of, I hate statistics. I see this every day with my students. I hated the class. I hate it. I don't understand it. I don't want to understand why I have to take it. And when I turn around and go, well, let me explain to you why or how this is important to you clinically, how you can use it, you know, the light bulb kind of goes off. So this isn't intended to be this normal, boring statistics class of the formulas. I hate formulas. I don't like formulas. I don't use them. I don't teach them. I really talk more about how you can identify the statistic that needs to answer your question, and then how do you interpret it in the context of the study and the patient that's in front of you. So I list all these things here of our description, our objectives, but really it's about making you more comfortable with stats. And again, I'm not a statistician, not an expert, but I've done enough, I think, to feel very confident to help relay to you guys how you can be more comfortable with reading the statistics, assuming, of course, that the researchers, the authors have done their job. So why is there such a problem with statistics in rehab professionals? Well, terminology is a huge issue, right? So what do all these words mean? And what do all these tests mean? And you get bogged down in this terminology. And not only is the terminology sometimes foreign, it's also contradictory or complementary, and you really don't understand what means what. You got to understand that statistics is more about philosophy than mathematics. You know, the big thing about stats is that you don't have to really have a true hard fast result to make a definitive decision, and that's, I think, the biggest thing you have to accept as a clinician is stats are really kind of actually vague. I hate to say it that way, but they're not pure mathematical. This is A equals B. It's kind of open to interpretation. So there's more of a philosophy approach to statistics that you have to accept going into it. Of course, few of us like math. Math is kind of intimidating to some people. Automatically, they just shut down. There are people that love math. There are people that don't like math. It is what it is, right? And then there's the problem of statisticians teaching clinicians. This is kind of the biggest problem that I see is you've got the statistician teaching clinicians about how to interpret stats in a clinical sense. I see there's a huge disconnect there. And not a knock on statisticians, but clinicians and statisticians have to come together. And that's kind of what I try to do in these talks, is to try to link those two together to help clinicians understand where the statisticians are coming from, what they're saying, and then how does that apply to the patient? Because I just don't think that a statistician alone could sit there and make a conclusion that you as the clinician can actually apply to that individual patient in front of you. And of course, the other problem is words and numbers just don't mix very well. It's just two totally different concepts that makes this a whole. I've spent a lot of time thinking about why are stats so intimidating and so bad for people. And there's all these different reasons that just come to this conclusion that stats just aren't the way they're presented. They're not very friendly presented to our rehab professionals. And I want to change that, of course, because it depends, right? So what does this stat mean? Well, it depends on the context. And that's what we're going to talk about today. Here's the problem. This study from 2019, look at the words. This is what I was telling you, Ash. Like, look at the incredible number of analyses that were done. Nothing against the authors here, but let's see, I think there were about 15, 18 different tests that they ran in this this paper. And the way that the words come across to a clinician is very foreign. And so typically what we do as clinicians, we just kind of gloss through that. We're like, okay, I just assume it's right. But that's where we miss the point, is we need to be able to be consumers of the results of the stats, not just to look at it from a critical standpoint, but also to interpret it. And in this example here, we went everything from the descriptive stats all the way down to, oh my gosh, correlations, ANOVAs. I mean, we ran every statistical test in this paper. So when you look at these things, like here are the different types of stats you can run. And I'm looking, this is why I'm telling you guys, I don't like formulas. I don't like formulas. You don't need formulas. That's what Excel is for. That's what, if you're fortunate, SPSS. I mean, there's online statistical calculators, there's all kinds of stuff. We don't need to know this stuff. Statisticians want you to know where all this is coming from. And I get that. I understand that you need to understand where these values are coming from and how they're calculated. I get that. But if you're a busy clinician, you don't have time to remember all these things. That's not what I'm going to teach you tonight, is how to calculate all this stuff. Because otherwise, it's basically just look like hieroglyphics to me. I mean, it's just, I really don't understand a lot of these formulas, and you can plug it all in. But as a busy clinician, we don't need to know this stuff. So why do you need to know stats? Well, I mean, clinicians, if we read a paper, right? So you're looking for that p-value. That's the problem. P is problem to me, although some people think that it means the p-value is anything else, but p-value to me is a problem. So P is basically what clinicians look for to say, was there a significant result? And what we're seeing is sometimes statisticians are telling us, well, P was significant. I don't think that statisticians should be telling us what's significant for patients. I think that the clinicians need to tell us what's significant. I'll get to that word in a minute, about their patients. And we'll talk about that in a minute. Again, I don't want to bash statisticians or anything like that, but what I want to point out is that statistics are what's in front of you. And what we've got to do as clinicians is to interpret those statistics from the statistician that's run these great stats. But how do we apply them to our patient populations? So that brings me to, of course, evidence-based practice, right? So we know the three pillars: the best evidence, the patient, and the clinician. Well, if we start with the patient, and how does that relate to research? That patient is based on a sample, which is based on a population in research that we're going to get to in just a second. Now, the best evidence is really about the quality and the quantity of the evidence. So you've really got to sit there and think about how well was this study done? Are the statistics representative of what I'm looking for my patient? And then as the clinician, not only are you applying your interpretation of the results to that patient, but you're also applying your clinical experience, what you've seen, kind of that intangible side of things with as you gain more experience. So these three things are why I think we need to be better consumers of statistical outcomes and the data that's produced by our research projects. Because at the end of the day, what we as clinicians are looking for are answers to many questions like, does this intervention actually work? Will this help my patient? Is this a good test that I'm applying for my patient to determine if they have a problem? And how can I reduce risk of injury? These are the common questions that we'll see as clinicians, but these are directly related to statistical outcomes that we need to build into our study. If you have a question, a research or a clinical question that builds to a research question, you need to have a valid statistical question that then answers your clinical question. That's kind of what tonight's about. So I'm going to start out with a top secret thing here. All right, Ashley, now be ready. This is top secret. Don't tell anybody this. It's not on the web.
Ready.
Are you ready? Stats is based on probability and assumptions. It's not an exact science. Whew, right? So this is the thing that you need to get across to people is stats is not this exact science. I'm going to tell you, P is probability. Okay, so probability has a little bit of less exact science. Mathematics is more of an exact science than statistics. So I just want you to kind of, let's start out here and realize that stats is about theory, it's assumptions, it's probability. It's not 100% black or white. It is not an exact science. So let's just get that off the table and let's just go with, okay, stats are stats and we're going to, but that means we have to use them. We can't use them black and white as they're presented, which is what most clinicians do. We have to think, put our brain behind it and figure out how does that apply to my patient, right? All right, big picture, descriptive inferential stats. Everyone knows that. The type of the statistics you use depends on the question you ask, right? So descriptive basically looks at the sample, just gives us the basic, here's what you see. I'm reporting what I see. The mean, the median, the mode, the percentile, the percentage, that's exactly what I'm seeing. Inferential, on the other hand, are what can I infer? What can I use this data based on the sample to infer to a larger population in order to do either estimate a parameter or to test a hypothesis? So this is important. We'll get into, you need to understand the difference here that an inferential statistic is really about using a sample and inferring the results of that small sample on the larger population. And within the larger population is where that patient of yours exists. So here, just a very brief overview. We're not, again, not going to get it. We don't have time to get into all the stats and stuff, but the descriptive stats, just describing what we have. The key here is it doesn't lead to causation. We cannot assume that based on our descriptive stats that something caused something else. That's a cardinal sin, if you will, in how we interpret stats. Inferential stats, on the other hand, we might be able to infer some type of result from the sample on a larger population, but it's got to be based on several assumptions, which we'll talk about in a minute. Now, the descriptive stats that you'll commonly see, things like, we know mean, median, mode, but you can also use things like coefficient of variation, how much difference is there between the scores of individuals, but the percentile, quartile, you may have heard of these things. And on the other side of your screen, on the other side of your screen here, we talk about the percentiles. You've ever heard of someone's in the 50th percentile, 90th percentile, that kind of stuff. We're basically just describing where that individual fits in a result in comparison to the rest of the population. We're just describing them. We're not doing any kind of cause and effect here. And this, unfortunately, or fortunately, if you will, it's very common to use descriptive statistics in a way that infers causation. So I just want to throw an example out here. Not a knock against the study or the authors at all, but I want you to start understanding that when you read these types of studies, the results are strictly descriptive statistics. All right. So the first lesson, basically about stats, that you're going to see here is we're doing a pre-post. What happened to these individuals after their total knee over the course of a year? The difference between right after they had surgery and then a year later, what happened with all these parameters, or these statistics, I should say. So you can see that there are means and there are standard deviations, and there are p-values, and we're going to talk about what that means there. Just because there's a p-value doesn't mean that the total knee replacement led to these changes. All we're doing is reporting on A versus B, the change between after they had the surgery and a year later. So I want to just kind of point out the first section of this is to be able to identify what a descriptive statistic is, and don't get pulled into the trap of causation, which I'll hit on a little bit later. This is very common in orthopedic literature. Where they say something like 85% of patients got excellent results. That's not causation. That's simply a descriptive statistic. Now, can you kind of assume that the surgery led to that result? You could, but from a purely scientific research standpoint, we cannot infer that that surgery caused that result. Okay, so I don't want to discredit anything of these types of studies where they report descriptive stats. I don't want you as a clinician, first of all, to start making assumptions that based on just because someone did a p-value, a statistical test, that they got significance, that their treatment was a significant cause for the result. That's the first thing. I just want to make sure we get kind of clear the air on that. So when we talk about cause and effect, remember, we went back to there's descriptive stats, inferential stats. You cannot infer causation from a descriptive stat. You can only infer the causation from this inferential statistic, but you have to do it based on certain assumptions that we're going to talk about. But bottom line is, no matter what type of stat you're using, it's the design that really matters the most. So the stat doesn't answer the question. The design of the study really answers the question. So testing a hypothesis, just looking at a p-value, just because you see p equals something, do not jump to the cause and effect conclusion by any means. That can be as simple as the difference between a pre and a post test. In one group, there was a significant difference between the two. You cannot jump to that causation conclusion. All right. Again, we don't have time to go through which tests should we use for all these things. What I did as I got a little bit more into this is I started looking at, okay, well, what are the questions that we're asking as a clinician? Kind of what are the research, the clinical questions? They're kind of listed here on the left-hand side of the chart here. If I'm asking to describe things, I'm obviously going to use a descriptive stat, which would mean mean, standard deviation, percents, whatever. And then if your question, and this is why it's important to look at the purpose of the study, the research question. The title sometimes can give you a clue. What's the effect of? Is there a difference between? Does something cause something else? This is where you would look for the mean difference between the groups, which you might use a t-test or a ANOVA. And if you're looking for what's the relationship or the association, you would use a correlation. There are a couple of ways to do that. There's also things like, what are the factors that cause something or related to something? Or can we predict something? That's another type of statistical analysis called a regression that we might use, linear or multiple. And then the last two tend to be epidemiological studies, looking at risk of injury or a condition, where we might use a chi-square. And then finally, there's the diagnostic type of study, which will look at things like minimal detectable differences, ICCs, interclass correlations, or the kappa statistic. So again, we don't have time to go through what each of these are, but if you go back to the title, the purpose of the study, you should be able to say, well, in order to answer that question, they should have used this statistic. That's the first kind of critical appraisal that I look at, is were they using the right family, I guess, if you will, of statistical tests to answer the statistical question. But there are still further things that I need to look at in terms of the specific test that they use in terms of parametric or non-parametric tests. So this is an intimidating slide because it really has all these different tests on here. So as you're a clinician looking like, well, this is why I hate stats, because look at this. This is incredible. I can't believe all these different things. What I want to point out here is stats are really not that intimidating once you look at them and think of them in this kind of algorithmic flow as clinicians that we do. And at the end of the day, if you look down here at the bottom, all statistical tests test a null hypothesis. That's what's interesting, is that statistical tests, like for p-values, are really about looking at what's the truth of the null hypothesis, which I'll get to in just a second. But I found that this kind of chart was really descriptive in terms of how I make a decision on which stat I should use. Now, busy clinician, do I have time to go back and look at this chart and sort through all this stuff and look at the stats and find out if the authors did the right thing? Hopefully, your researcher, your reviewers, your editors, everyone has done a job of reviewing the stats, which we do at our journal, to make sure that the right stats are used to answer the question. So you can go in with an assumption, first of all, that the right stats were used based on the question. The problem is, as we'll talk about, is predatory journals that don't follow strict guidelines of peer review. For example, if you were looking to use those as a source, which I wouldn't totally recommend, you should be able to go back and look at, were the right statistical analyses used based on the question, as well as the outcome measure and the population. Those are three big things that we look for to choose which statistical test to use to answer a question. So this just here as a reference. No need to memorize it. It's something I actually kind of have on my desk, just kind of there to remind me if I have a question on a certain test that I would do. So don't get too excited. Don't get too worried. This is not the purpose of this presentation, to make you hyperventilate over all these different tests. Don't worry about that. We're going to get better. Trust me. But in order to move forward with this, what I need to do is kind of explain to you what hypothesis testing is about. Okay. Hypothesis testing, which is what significance testing, really null hypothesis testing is about, significance testing, is this alpha and beta, basically. So the way that we do statistical testing is based on the parameters of getting a false positive or a false negative, basically. And what we look at is a contingency table like this, where what the researcher does is, do they accept or reject or accept the null hypothesis? And in reality, is it true or not true? Is there not a difference, or is there a difference? And so the two types of errors you've probably heard of that we've talked about in the past will be a type 1, which is a false positive, meaning that the researcher says that there is a true difference between the two. And a false negative means there is no difference between the two. But there really is a difference between the two. So that's the difference between type 1 and type 2. When we talk about alpha, which is what most of us look for, p-values. P-values is the probability of the researcher having a false positive response, which is 5%. So when we look at a p-value, it's basically telling us what's the probability that we're willing to accept or that the researcher is willing to accept, that they say that there's a difference between the groups when there's not. That's the false positive. Okay, that's what alpha leads us to. Our p-value is what's the probability of saying there's this difference between the groups when there really isn't. So a 5%, 0.05% alpha is that I'm willing to take a 5% chance that I made, as a researcher, I made an error saying there was a difference when there really wasn't. On the other hand, the type 2 error, which is represented by beta, by convention, is 0.2. We a 20% probability that I concluded as the researcher that there was no difference when there really was. So that's how this all comes together and how we put together our alpha and our beta. And we're going to talk about the p-value, which we've mentioned with alpha, but also power, which is related to beta. The take-home point here is that significance is not a quantity. And I hate the word significance. I don't understand why we use that or why it's interpreted as that from statistical significance. Remember that by convention, statistical significance means that our p-value was less than our established threshold, which is typically 0.05. So when something is less than 0.05, we say significant result. Well, clinicians, we tend to just automatically significant is large, great, grand, awesome. But really significant means that it was less than 0.05. That's all it means. You cannot come out and say less, like a very significant or awesomely significant or barely significant. It's basically yes or no. Either it was less than 0.05 or it was greater than 0.05. And you're going to see this with people that write papers will say, we barely reached, or we were near statistical significance with 0.49, or we were very significant with 0.01, 0.001. Significance, by definition, with a p-value, it's either yes or no. There's no quantity associated with it. Now, you can infer that someone who has a 0.001 p-value, that's very significant. But in statistical terms, it really is just either yes or no. So back to what p-value means, it's a high probability that a false positive did not occur, 95% chance. And we use 0.05 as that 5% as a standard convention. No one really says that's what you have to use. It's just what someone chose, 0.05, 5%. If you want to choose 0.25, 0.4, I don't care. Doesn't matter. That's what is typically used is 5%. All right. So there's a 5% chance or probability that if I, as a researcher, reject the null hypothesis, that I did it incorrectly. That's what the p-value tells me. The flip side of that is that the p-value also tells me there's a 95% probability that the true value of the population that I'm looking for based on the sample exists within the certain range. That I have a 95% confidence that the true value of the population exists here, and that there is still a 5% chance that that value doesn't represent the true population. That's basically the way I interpret these p-values as a clinician. There's always this 5% chance that what I'm seeing isn't really going to be the true value that I'm looking for in the population. So, yes.
I don't know if this is a good spot to ask this question, but just to be sure that I don't miss it. James asked, the Dunning-Kruger effect shows that individuals have a bias which can influence interpreting statistics. How can we challenge ourselves to reduce bias in applying the results of the stats and treating patients? And you might be getting to this, so I just wanted to make sure we threw it out there.
Not familiar with Dunning-Kruger effect, so if you could expand on that a little bit more. And how, I mean, obviously we talk about reducing bias. We'll talk about that in a little bit. But I'm just honest, I don't know what Dunning-Kruger effect is. If you wouldn't mind, James, explaining that.
Well, if we're going to talk about reducing bias, I think it might cover it a little bit, but we'll
yeah,
if we need
for
to.
sure.
Cool. All right, I'm gonna mute myself.
So, well, the bias here is really about avoiding making your decision based on p-values. So, and remember that hypothesis testing, null hypothesis testing, is what we're doing with p-values. So all we're doing is testing a null hypothesis when we reach a p-value. The p-value doesn't mean much to me as a clinician on making my clinical decisions. So are they really relevant to how we as clinicians can make decisions? That is the big question here, right? All right. So remember, over here is a study that you read in the journal with a sample, assuming that it's large enough, and that it's supposed to represent over here this population of individuals of which your patient exists. So remember, your patient is not in this sample, right? Your patient over here is part of a population that is supposed to be represented by the sample of the study that you're doing. So the first question you need to ask is the sample of the study you're looking at representative of the patient in front of you or the patients that you treat? Now, there's always going to be this give and take with populations or with samples of inclusion, exclusion criteria, and you have to look at those very closely. Does this represent my patient? In the world of research, the problem with inclusion, exclusion, and homogeneity is that we sometimes exclude individuals that are more representative of our patient population. So they're kind of skewed towards this very homogeneous, well-designed population that we don't always see as clinicians. So you have to take that with a grain of salt. Just understand that you want that population or that sample of the study to be as representative as possible of the patient that's in front of you. And a little clarification here, when you talk about stats, a statistic actually refers to the sample and the parameter actually refers to population. Now, you've probably heard we talked about descriptive stats, and there's also the inferential stats, the other side of that. I mentioned that we can only use these inferential stats based on assumptions. And these are, what I call the big four, that you have to have the appropriate size of the sample. You have to have a very homogeneous population that has variability at the same time, but that the data itself is normally distributed to represent what a normal population would look like with a normal distribution, as we see over here with the normal bell-shaped curve that's not necessarily skewed one way or the other. So in order to do that, to see if our population or our sample represents our population, we do specific tests. There could be several tests that we could do for tests for normality or variability to actually look at, does the sample adequately represent what a population would look like? And there's also a power analysis that we have to do. Is the power or the sample, the sample size large enough to give us the ability to make that inference, and which I'll talk about in just a minute. Now, if your sample doesn't represent your patient, it doesn't mean you just throw it away. It just means you kind of proceed with caution a little bit. Maybe it doesn't meet all the assumptions. I think you could still use that information to make your clinical decision, but I wouldn't like hang my hat on it with 100% confidence by any means, right? So when we talk about power, and for us old guys and girls in the group, remember the power of gray skull. Ashley's probably too young to remember the power of gray skull, but the power of statistics is kind of a nebulous thing that a lot of clinicians don't understand or appreciate. Basically, the power that we get of a study is the ability to avoid a type 2 error, which is that false negative. By convention, it's 1 minus beta, which turns into a 0.8. is what we look for in our power. And power is definitely influenced directly by sample size. So the larger the sample size, the more power that you would get. So the lower the sample size, the more potential you have for a type 2 error. So we have to make that clear, is that when you're using a smaller sample size that doesn't reach that power that we need to make our inference, you really can't use that sample as a representation of the full population. And that's a very common thing with randomized controlled trials, for example, or other types of studies that have small sample sizes, because we tend to use, or researchers will tend to use these small samples without adequate power, which they call kind of pilot studies, and yet they make statistical inferences from them. They'll run parametric tests. Not a good idea, because a parametric test, as I'll talk to you about, is really based on the assumption that you have made that sample representative of the population. If I don't have the adequate size of my sample to represent my population, how can I do a parametric test? How can I make an inference based on that? So when I look at a pilot study, which generally means it had 5-10 subjects, I don't like to see parametric tests. I don't like to see p-values with that. Or if I do, I again take them with a grain of salt. It's okay if you do it, but there are better ways. You can't necessarily infer those results on your patient population. And when they do this power analysis, they typically use a program called G-Power. There's other types of things out there. And you want to do it before the study, not after the study. That's another thing to look for, is to make sure that the researchers are doing what we call a priori testing for a power analysis. So we talked about parametric, non-parametric. So parametric is obviously something that refers to a population. It refers to a parameter which is representative of a true population, whereas a non-parametric type of test would be something that is not representative of a true population, which may be a small sample size, for example, or low, or there's no variability, or they're not homogeneous. So there are two different types of stats that we can run based on the sample. And is that sample actually representative? Is it large enough? Is it homogeneous? If it's not, then we have to use these non-parametric tests. The other part of the equation is that parametric and non-parametric testing is also based on the type of variable, type of outcome, the way that it's measured. For example, a parametric measurement would be a ratio or interval, which would be basically anything from that has a true zero or goes from 0 to infinity or through infinity in a continuous measurement. That's a continuous outcome variable. And the discrete variable, which would be an ordinal or a nominal variable, would be something like a yes, no, a binary outcome, or it could be an ordinal variable like a rank order, a Likert scale, 1, 2, 3, 4, 5. When we have those types of measurements, we have to use a non-parametric statistical test. And the reason that we have to do this is because the way that the tests, the formulas are developed is, again, taking assumptions into consideration in how we analyze the data. And it's much harder to get a significant outcome from a non-parametric test, which is why you need to watch out that sometimes researchers will run parametric tests with non-parametric data, because it's easier to get that p-value that they're looking for, that significance, which I'll talk about in a second as well. So is hypothesis testing really relevant? Well, there's a lot of limitations to it, obviously, starting with the sample size and getting the right number of people, but also the variance and difference. You have to have that balance of variance and homogeneous as well, and representation of a patient population. So hypothesis testing is kind of limited in terms of a clinical application. We talked about the fact that p-values are relatively just arbitrary in terms of 0.05 just set. They're dichotomous, meaning yes, no, and they're just a probability of 95 to 5%. So it's really not that much of a black and white decision. And finally, I do get criticism from some people because I do a lot of p bashing in clinical research and stats. But what I'd like to point out is there is value in p-value testing. There is some when you have a very well controlled environment and you're looking at things that don't have a lot of these influences with these assumptions on clinical variability. You're looking at things where it's really tough to control in clinical studies all these different factors that go into human studies. Hypothesis testing, p-values, great. And we talk about things like very controlled lab studies. So I'm not here to totally throw away or pee on p-values by any means, but I just want to make the point that they only have so much value when it comes to making a clinical decision. So one of the things we need to really just clear the air about is what a p-value isn't. And I hear a lot of, oh, it's just the amount that the probability that it happened by chance. Well, it's not the probability it happened by chance alone. It just means that there's a 5% chance that something else may have led to that change that we see. In reality, it still goes back to there's a 5% chance that the true value of the population doesn't exist within the parameters that we've established based on the sample that we saw. So remember that the p-value doesn't tell us the probability that the results are due to chance alone, or that the null hypothesis is true, or that there's a huge difference between the two. Again, the word significance, I just wish we would never use that word significance, because we tend to think of it as this more of a measurement of size than more of a yes/no decision, which is what the p-value is really what I call an idiot light. It's either on or off, yes or no. So I see this light on my car. I still don't know what's causing this light. Yeah, I know that there's a p-value that's less than 0.05, but what does that mean to me? And that's where we wanted to kind of bring back this discussion tonight and talk more about how do I interpret that value beyond just the p-value, because just using the p-value doesn't mean that there's a significant or a causation, right? We mentioned this earlier, that it's not the stats, it's the design that looks at causation, and that these observational designs, and that's why it's important as a clinician to be able to look at a study and determine, what is my design here? Is this one group pre-post test? Is it two groups pre-post test? How am I controlling for the comparison between the groups? It's really important as a clinician to, again, be very oriented to the type of design based on the question. I always go to the purpose statement, right? The purpose statement should then lead me to the design, which then leads me to the stats, which then leads me to the answer to the question or the original purpose. So back to our original example earlier in the talk, that a simple pre-post design of a cohort that reports p-values is still observational. There's no cause and effect here. It's just saying that group got better or it got worse, and it was a yes or a no. Did it get better or get worse? It doesn't tell you. The p-value doesn't tell you how much they got better or worse. Even if the p-value is 0.00001, it doesn't tell you how much better. What it tells you is that you have a very good probability that the results that you saw with that sample represent the true value of the population. That's all the p-value tells you. It doesn't tell you how much better they got. It just tells you how representative the results of that study were on the true population. And yet it's very common in literature that we see this, that people try to infer causation and they use it with causal language. And these are some of the words you might see. Obviously, cause, effect, improve, impact, results. These are things that you're going to see that people infer causation, maybe rightly so, maybe not. But then on the other side, be careful on the non-causal language. Association, relationships, correlations. These are not causation. So the biggest thing we look for, particularly in clinical review or as an editor of a journal, is you look at the conclusions, and based on the statistic that was run, the design of the study, can that researcher come to that conclusion? Really, the only way that you can come to that conclusion is based on the design of the study, and kind of the stats kind of support that outcome. But these words are very powerful, and people who write articles use them to get published many times. So it ends up in the hands of the reviewer, in the hands of the editors, copy editors, to make sure that the words that these individuals are using are not leading to a conclusion that we should not have reached based on the design or the analysis. Which leads me to one of my favorite points, the significant correlation, right? So you got an R value of 0.02 or 0.2. The R value is 0.2 and it's significant. So then you say, well, there was a significant correlation between them. But do you know what a 0.2 correlation is? It's not a good correlation. So when you look at a correlation, this is where significance, again, kind of rears its ugly head here. A correlation has two parts to it. It's the size and the reliability of it. And that's kind of true with just about any measure, is that there's an effect and there's this kind of how true is it. The truth goes to the p-value, the reliability. How much can I rely on that measurement to really refer to the true parameter, the true result in the population? That's the reliability, is what p-value tells me. But the R value of a correlation, for example, anywhere from 0 to 1 plus or minus 1, tells me the strength of that correlation. So if I have a correlation of a 0.2, which by some people would say it's negligible, it's nothing, but yet it was significant, the p-value was less than 0.05. What does that tell us? All it means is that the probability of that value of 0.2 is 95% representative of the true value of the population, right? A p-value of, greater than 0.05 with a correlation of 0.8 would mean that, yeah, this sample had a really great correlation value, but the chances of it actually representing the population are not good. And that's what the p-value tells us. What's the probability that that answer, that statistic that we got from our sample, is representative of the entire population? So when you look at the correlation values, be sure and look not just the R, but also the P, and make sure if you really had a nice high correlation above like a 0.5 with a nice p-value less than 0.05, chances are that you have a really nice correlation that is representative of the population based on the assumptions from your sample. P-hacking. So this is why we have to be watching out. This is why we have to know our stats, because people want to get published. What's the old saying? Publish or perish, right? And so that created this environment of predatory journals, which are out there, which are basically pay for published journals, which don't have adequate peer review. Not to classify all of them, but you can usually tell these predatory journals tend to be, I also have developed this, or kind of coined this pseudo predatory, where they're basically journal farms, where they're all pay for publish. You can tell by the articles, they're just not high quality. They may go through peer review, but it's very fast. It's not very accurate. And these articles get through, and they're often full access. That's not to say, and I always make this disclaimer, a open access journal does not mean it's predatory, right, Ashley? Our journal is open access because we believe that you should have access to your articles but still have adequate peer review. And that's what IJSPT is all about. Whereas others may have you pay $2,000 to publish an article, and they may have good peer review. Now, there are credible journals with open access that do charge costs for it. I'm still not really sure why that happens, but one of the things that we do as our journal is we do promote open access and adequate peer review, and then it actually goes through several layers of review. So anyway, back to the reason why people are doing p-hacking. P-hacking is really about manipulating the results to lower the p-value so that it is significant. And why do they do that? So they get published. For the life of me, I can't understand why today journals are still rejecting papers that aren't statistically significant. I don't understand it, because for me as a clinician, I'm like, well, good. I'd like to know if something didn't work, because I don't have to do it. I don't have to waste time on it. Or maybe I can modify it and get to that level where it is helpful. So I don't understand why journals are just rejecting not significant findings, but that's why some researchers may feel this need to manipulate the results by changing the tests that they do, like we were saying, maybe from a non-parametric to a parametric, or changing the power, the results. And typically this is just not a good practice, which is why we have to register our trials before we actually publish them. It's good practice to register your trials so that you don't go or get caught into this potential for hacking of the p-value, which artificially deflates the p-value in order to give you significance. So what do we do without p-values? That's when, oh my gosh, I go to the end of the results section. What do I do if I just see p-values? Oh, well, unfortunately, I think that's what researchers doing clinical literature need to really step up here and report on estimation statistics or clinical statistics in order to give us that ability to make better decisions clinically. And statisticians know these things, but I think sometimes we don't communicate well with statisticians in terms of what clinical things do we need to know to make a better decision. The p-value, like I said, doesn't give us much information. It's just a yes, no. Do we feel that the researcher made the right decision about rejecting the null hypothesis? That's what the p-value essentially tells us. What does that mean for my patient in front of me, right? Well, in order to make that decision, I can look to several types of stats. The effect size, the confidence interval, and the MCID, or minimal clinically important difference. So the effect size, so I talked about the word significance doesn't mean magnitude. It just means yes or no. The effect size gives us the magnitude of the difference, as well as the direction. Is it a positive or a negative change? The confidence interval is actually very related to the p-value, in that it is the 95, or if you want to say 90%, but it's the 95% range of possible values in the population. So a confidence interval is really a representation of the p-value. The p-value is 0.05, 5% chance that the answer does not exist within that range in the true population. And the MCID is going to be what is the minimal difference between, or change, or relevant change that we should see in order for me as a clinician to change the way I treat, or as a patient, what's the minimal difference I would like to see as a patient? For example, in pain measurements, would I like to see a drop in my visual analog scale, or my numeric pain rating scale from an 8 to a 7, a 1-point difference? Or would I want to see more than that, maybe a 2-point difference? That's what the MCID tells us. So we'll talk about the effect sizes first, and what you want to look for in making a decision from a study is based on the size of the difference between the groups. It goes beyond this yes, no. It's basically the effect, the size of the effect. And that size will vary depending on the magnitude of the difference between the two groups. So when you look at effect sizes, what we typically, when you see the word effect sizes, we think of Cohen's D. That's this value right here, which is also known as the standardized mean difference between two groups. We're actually looking at the mean of group A, the mean of group B. What's the size of the difference between the two divided by the standard deviation? So that's the standardized mean difference would be Cohen's D value. By convention, we tend to use these terminologies from Cohen, a small, medium, or large interpretation. If your effect size or your Cohen's D is less than 0.2, it's trivial. 2 to 5, it's small. 5 to 8, it's large. Above 8, it's it's large. And that's the size or the magnitude. And these can be negative as well. You can go in the opposite direction. So you can have a minus. And this is important with things like pain. You want pain to go down. Some functional scales or some scales you want to go down. So be careful in looking at the negative value means that you went in the opposite direction, which may be a good thing. So effect sizes can be positive or negative. And then you have other types of tests besides Cohen's D we think about, but your variance, your correlations, your predictions, all these things are also considered to be effect sizes because they relate directly to the magnitude of the statistic, not the p-value, right? The p-value is still yes or no, but we can apply this number over here based on the statistical measurement that we're doing, or this value in our statistical test. What is the size of the effect? What is the size of the correlation? What's the size of the relationship? Okay. So these, again, I'll have to say they're arbitrary as well, that these values are just kind of pulled from different sources. I would tell you that a good example is Cohen's D is a good example here, that these differences can vary depending on the population or the sample that you're testing. Athletes, an effect size for an athlete is totally different than these effect sizes. Cohen's effect sizes were generally designed more for the psychological literature. There was a lot of work that was done more in the sports conditioning literature on the standardized mean difference using Cohen's D that would show that these values are a lot higher, right? So again, effect sizes depend not only on the statistic you're testing, but also the population and the outcome. Moving a little bit towards still within effect size, there's something called odds and risk that are considered effect sizes, but they are also under the framework of epidemiology, and they do go beyond epidemiology, and I'll tell you why in a minute. But odds and risk values that you're going to see in the literature as a rehab professional, you'll see things like odds ratio, risk ratio, absolute risk reduction, relative. All of these are based on this, something we call the contingency table, or the 4x4. Basically, you'll have, was the individual exposed to something and what was the outcome? And so you'll basically have this type of arrangement where you can then determine what are the odds or the risk. Now, this is another reason why stats are confusing to a lot of individuals, because people interchange the way that these words work, first of all. And they're kind of ambiguous. They're kind of what's the difference between odds and risk, right? Statistically, I can show you that there's a difference between odds and risk here, but the way that I interpret this, and that most should be interpreting this as a clinician, is that the risk ratio looks at things in the future. What's your risk of falling? What is your risk of getting an ACL injury? What's the risk in the future? Okay. And when I see a risk ratio of 1, a risk ratio of 1 means there's no difference between these two groups. So going back to this previous slide of what an effect is, let's see if I can go back here. I don't know if I can go back. Oops. So you'll notice here in the effect sizes, we have null values of all of these test statistics except for an odds or a risk ratio is actually 1. So when you see an odds or a risk ratio of 1, it means essentially of 0. It's a null value. Now, that's risk ratio. If I have a risk ratio of 2.0, it means I have twice the risk of something happening in the future. If I have a risk ratio of 0.5, it means I have a 50% chance. I'm sorry, half the risk of someone else going into the future of that happening. It's a lower risk. So remember that 1 is the 0 value, basically. There is no change in risk. Either you're above or below it, above or below 1, either you're at a lower risk or a higher risk. That's based on the value of 1. An odds ratio is based on what we saw in the past. So odds ratios are commonly used in cohort studies to report on the number of people who got better in a treatment compared to those who didn't, with a treatment compared to those who didn't get a type of treatment. And that's so when you think of odds, it's more thinking in the past. So same thing happens here. A value of 1 means there was no difference between the groups. You have an odds ratio of 1, but if you had, again, a 2, an odds ratio of 2.0, there was twice the odds of someone getting that result based on that treatment. And this tends to be a pretty good way of looking at cohort studies that have been done in the past, retrospectively, and making that kind of conclusion based on the size of the response, the so-called effect size. The last thing you'll see here is the number needed to treat, which is related to the absolute risk reduction. But the number needed to treat, if you see that number, it really means the number of patients that you have to treat with that intervention to see the desired outcome. And the lower the number needed to treat, the better that treatment is. So if you do see NNT, you want to see numbers that are lower as a good indication that it's a good clinical study intervention. All right, no, I'm running behind, Ash. I'm sorry. I don't know why I got a little geeked out, but we're going to move on real quickly to confidence intervals. We kind of mentioned those, the 95%. A confidence interval is basically the range that represents the true values of the population based on the sample that we're using. And when you look at the more narrow the confidence interval, the more precise the estimate is. The wider the confidence interval is, the less precise that we are with this. But it provides us with an estimate of what we think is the true parameter of the population. And so we can use that point estimate. It's either that difference, could be the effect size. So the first thing to look at with these confidence intervals, with their point estimate, is what is it representing? Is it representing a true value of our measurement, or is it representing something like an effect size? And the key here with confidence intervals, if that confidence interval includes 0 or the null value, the reason why I say that is remember that risk and odds can have their null value as 1. So if a confidence interval includes the null value, whether it's 0 or 1, we consider that to be not statistically significant, which means that if you see a confidence interval and it does include the 0 or the null value, basically you're saying that there is still a chance, it's within the realm of possibility, that the result that we saw with that sample is not representative of the true population. So when you look at different confidence intervals, and this is an example of how to read these I'm going to look at this and I'm going to orient myself with my graph here. And this is looking at effect size, which again, let's just say it's Cohen's D, between -1 and 1 with magnitude and direction. So if you look at this confidence interval, the little box here is the point estimate. The point estimate here is, I don't know what that is, maybe 0.3 effect size. So beyond trivial, but you'll see that the interval is small and it's also doesn't contain 0. So this is a significant statistically significant results here, where this one is very wide, so it's less precise, but it also includes 0. So it's not statistically significant. Again, statistically significant here, but a wider confidence interval. And then here, even though we have a narrow confidence interval, we still have no difference, still includes 0. Now we can apply that not just to the effect size, but also the minimal clinically important difference. Where does that MCID fit within the confidence interval? Does the result of our sample actually include the MCID? That's the question. If there's still a statistically insignificant result, does that confidence interval still include the possibility of reaching the MCID? Which then again totally throws the p-value out of the window, meaning I really don't care about the p-value. If I have a 95% range of confidence that the possibility of reaching my MCID is within this range and it's pretty narrow, I'm still going to say that's a very viable type of treatment, right? So in this example here, we have an MCID of 4, but it is not statistically significant because simply it includes 0, but yet there's still a lot of room here for improvement. So I think that in this type of result, we still have the ability to use this intervention, even though it's not statistically significant. That confidence interval still includes the possibility of reaching our MCID. So that MCID, which you can look up, basically the issue here is it varies with the population, with the test. So just because you would have, you would say, what's the minimal change for pain? Well, it depends. Which type of pain? You're talking about knee pain, arthritis pain, you're talking about emergency room pain. So you need to make sure you're very clear on exactly what type of pain or what type of test you're looking at to see what the minimal difference is. But it does give us a lot better clinical, I think, information rather than just that p-value. How can you find these? Simple. It's just Google. If you type in Google and you go, what's my MCID for something, you'll find it. You can also find effect size calculators and confidence interval calculators just by Googling that. Some basic sites like Pedro, the Center for Evidence-Based Medicine, or Psychometrica also have tools that you can access. And then the Shirley Ryan Lab, Abilities Lab out of Chicago, has a fantastic database, free to access, of all these tests, which include not just MCIDs, but they'll talk about the reliability and all these different types of psychometric properties of our tests. I'm going to skip forward right here as an example as we round this out of how to look at confidence intervals. We tend to see these mostly in our meta-analyses. And a meta-analysis will collect data from several studies, put it all together, and then kind of group all of these. And this was a study that was done on the effects of kinesiology taping on pain and disability. So the first thing I want to do is orient you on the graph here. So we start at 0. What is the 0 level, the null? There is no difference between taping and not taping on pain or disability, right? So there's no difference between the two. Over here, we find that tape is less beneficial. Over here, we see tape is more beneficial. Remember, we talked about negatives and positives. So when we're talking about pain and disability, a negative value is actually good. We're decreasing pain. We're decreasing disability. So a negative value is good in this situation. And so you would want to see something more in the negative side where it's decreasing on effect, if you will. We'll start by looking at what was the difference between kinesiology tape and a minimal intervention on pain. And this little spot here is our point estimate. What do we think is the most likely representation of the accurate estimate of the statistic of the parameter in the population is minus 0.68 right here. So the effect of tape was a decrease in pain with an effect size of 0.68, which is pretty good. And the confidence interval ranged anywhere between a decrease effect of 0.1 to 0.25 on the negative side. So you'll see that it doesn't include 0. So the p-value is going to be less than 0.05. Okay, so if that confidence interval does not cross 0, p will be less than 0.05. So that makes sense to me right here. Sometimes you might see, we've picked up on this sometimes where confidence intervals are reported either incorrectly or correctly, and the p-value doesn't equate. If you have something where you have a negative here and a positive here, you should have a p-value that's greater than 0.05. All right. The next thing that this study did was looked at disability with kinesiology tape versus minimal intervention. They had a lower effect here of 0.41, which is small, better than trivial, still small. And here's the range of the confidence interval. This is what I want to point out here. It's a minus 0.83. So there's a chance, 95% chance of this range of the true population, either you're getting a 0.83 effect size or a 0.01. So the p-value is 0.05. So that's not statistically significant. So you throw that out. So you're telling me that all of this value here is wasted, because in the abstract, it'll say there was no significant difference using kinesiology tape on disability because my confidence interval included 0 and 0.01. You see that here? That's why the p-value is 0.05, which goes back to my argument. It's either is or it isn't. So the results here are that statistically, there is a chance within the 95% realm of probability or possibility that the true value of the population, there is no difference. But there's also within that a good chance between that and 0.83 of it happening. So there's still, the point estimate is still a 0.41 effect size. And yet, if you read the abstract, you throw the baby out with the bathwater, and you've lost the possibility that this might have a good effect on your patient with that effect size of 0.41, simply because the confidence interval crossed 0. Okay, summing it all up, what do I do with all of this stuff tomorrow morning as I'm reading my articles, right? Look at the article. How do I apply this? If I'm looking at an article, how will it benefit your patient that's in front of you? First of all, look at the sample. Is the sample representative of the patient that's in front of you? And did they meet the assumptions of a sample representing a population? Okay, that's the first thing. Next is, what was the design? Does the design of the study answer your clinical question? Are we looking at cause and effect? Are we just looking at observational? What does the design tell me? And finally, what are the outcomes? Are the outcomes relevant to what I'm looking for in my patient? And are they valid in how they're measured? Now, that's the basic design of the study, right? And then once I get the stats and look at it, I'm going to look at that p-value. I'm going to go like, yeah, okay. But as I've shown you, just because it's significant or insignificant, that to me doesn't answer the clinical question all the way. I still got a lot more information I want to know. What's the effect size? If I can't find it, and unfortunately, authors don't always report effect sizes. They don't always report MCIDs and confidence intervals, and that's why we have to sometimes go back and find those calculators, right? The good journals, the good articles, they will include these types of clinical outcomes, particularly effect sizes. If nothing else, just give me an effect size and a confidence interval. I can go back up and go look up our MCIDs. But what I really want to see out of my authors is what's that confidence interval? How confident are you in your result that you did? And then as we round out, the last question is, are they relevant to your clinical population? Just summarizing, is the sample relevant to you, representative? What are the outcomes? Try to use that MCID and then convert it, whatever stats you have, if at all possible. So with that, I will thank you for your attention tonight. Thank you, Ashley, for hosting, and the journal for having me on here. And I hope that this has been somewhat entertaining, even though it was quite long. I apologize for that, but you know how us nerds get. We got a little too excited. So thank you.
And I think that was great. And I've been like sitting here scribbling notes the whole time as well. So I have a few good takeaways. And the main one being, don't just read the abstract and see not clinically significant and just walk away from it altogether, you know?
Right. That's exactly right. Yep.
So I think that's great. I think these are really good key takeaways, especially for someone who isn't a researcher and is more of a clinician in the trenches. And it's really overwhelming when, you know, every day there's a new paper, multiple papers that you're seeing, and you're like, I don't even have time to read this. Like, what are the key things you want to scan for, look for, what's relevant, and how to apply it? So that's, you know, the goal of tonight. And I think that was great. So if there's any questions, we're happy to, if you want to pop them in the Q&A section or in the chat, we're happy to answer.